Okay, this is our presentation. We're Team Rockies. We're made up of David, Denise, myself, Brian, and Leah. Here's our case. It's a 25-year-old female, has been admitted to the ICU after a motor vehicle accident, MVA. She has no prior medical history and was very active in intramural volleyball. The PT knows ICU-acquired weaknesses can be minimized with early mobility, and basically our research question was, should the PT choose the Physical Function and Intensive Care Test, PFITS, or the ICU Mobility Scale, IMS, to measure function for this patient? So here's our background. These are the keywords that we use to find our research to support our answer, which you'll see later. The keywords are PFITS, PFIT, ICU Mobility Scale, Functional Outcomes, ICU. The search engines we used included CINAHL, and that's the one through Creighton Library. A little bit about the PFITS is it's intended for patients that are critically ill in the ICU. It's used to guide exercise prescription, and it measures functional recovery. It should be administered when patients regain consciousness and can follow verbal commands. Otherwise, it cannot be used. And here is a little bit about the IMS. That's intended for adult patients in the ICU. It's an 11-item categorical scale. It measures highest level of functional mobility of patients in the ICU. We'll explain that a little bit more in a bit. And it should be administered when patients regain consciousness and can follow verbal commands. So same as the PFITS. Okay, here's our methods. I'll tell you a little bit about each functional mobility test. So the PFITS procedures starts off with sit to stand with assistance. And then we have MOS, which is march on spot. It's as long as possible, so you just march in one spot for as long as possible. And then after that there is a shoulder flexion manual muscle test and a knee extensor manual muscle test. The normative values for PFITS you can see on there. The highest score you can get is a 12. So here you can see the sit to stand. If you're unable to do it, you get a 0, but if you could do it with no assistance, it's a 3. Then you have marching spot, steps per minute, so 80 plus per minute is a 3, and unable to do 1 is a 0. And your typical manual muscle testing for shoulder flexion and knee extension, you see the grades from 0 to 5. 0 to 2 is a 0, and a grade 5 is a 3 for each manual muscle test, as you guys have learned already. And here we have the ICU mobility scale. It is based on a scale of 0 to 10. 0 being, as you can see, lying in bed, all the way to 10, which is walking independently without gait. So basically, you give them a 0, or you give them a number on what type of functional mobility they're able to perform. So they're able to stand, and that's it. They give them a 4. They're able to transfer from the bed to the chair on their own. It's 5. Able to walk independently with gait aid is a 9, and so on and so on. So you just give them a scale from 0 to 10, and on how mobile they are on their own. Okay, here's our statistics. We'll start off with the PFITS. PFITS had a moderate large criterion validity between PFITS and other functional mobility tests in the ICU. It performed better against IMS, as you can see there. Had excellent construct validity with measurements of muscle strength, and it had a higher. If the PFITS score was higher on awakening, it was good at predicting if the patient will discharge directly home, which is a great find that they discovered. The MCID is 1.5 out of 10, which is great. The effect size is 0.71, so that's pretty good too. The floor and ceiling effects, as you can see there, small effects at awakening is less than 11%, small effects at discharge is less than 11%, and reliability was 1.5 out of 10. Here's the ICU mobility scale statistics that we found. MCID was 0.89 to 3, so could be greater than PFITs or less than PFITs. So seemed like the PFITs was more reliable in that case. The criterion validity was high for the IMS, and moderate construct validity, and upon discharge, a moderately positive correlation between PFITs and IMS. And reliability, affected by patients' changing status in mental capacity and physical health. The inter-rater was really great in terms of experienced physical therapists versus new physical therapists, and also for nurses. So that's a good find for the IMS. And floor and ceiling effects, you can see there are floor effect is 16.7% and ceiling effect was 0%. The effect size is 1.4 at discharge, so that's higher than the PFITs, which was 0.71, which is really great for the IMS, but it seemed that PFITs was more reliable overall as a functional mobility test when compared to the IMS, and that's basically the research that we found to support that, and that's why if you ask which one is better between PFITs and IMS, we're going to answer PFITs. It's moderate to large criterion validity, has a higher PFIT score, is better at determining if a patient will be able to go home upon discharge, upon awakening. Excellent construct validity with measurement of muscle strength as well. And like I mentioned, it has a moderate effect size compared to the IMS, but overall as a functional mobility test, it seems to be more effective at telling how the functional mobility will be for a patient in the ICU. And here are our references. So yeah, if you guys have any questions, you guys know what to do. Thank you so much for listening to our presentation.